have on his forehead an indication saying, I am hyponatremic. The only way that you can judge whether the sodium content is normal, because that counts for the volume of the extracellular volume, is by doing a good physical examination. And we will come back to that. On the other hand, probably the most common cause of hyponatremia is when there is too much water relative to the sodium and the potassium. So then your total potassium can be normal, and still but you will have too much total body water, so you will have hyponatremia. Your total sodium can be decreased, so both your sodium and your water decrease, but your sodium decreases more than the water, you still have hyponatremia. So a common error that has been made by young fellows, they equalize hyponatremia as volume depletion. That's not correct. Most of the cases of hyponatremia are the patients are euvolemic. They have a normal sodium content in the body. Your sodium concentration only tells you the relation between salt and water. So it is the relation. It doesn't tell you whether your patient is hypovolemic or euvolemic or hypervolemic. That you have to determine by physical examination. You will not find this in the Russian version, because I added that yesterday, because I think it's a very easy and educationally important slide, which was published in Jason last year. Meaning, the sum, and that's a nice parameter to determine if you're confronted with a hyponatremia. You measure the sodium and the potassium in the urine, and you divide that by the sodium in the blood. That gives you an idea how diluted or how concentrated your urine is. And if, for example, the urine to serum electrolyte ratio, sum of urinary sodium, urinary potassium divided by serum sodium is 1, there can be no impact on the serum sodium, because you're excreting a tonically isotonic urine with your plasma. It's always in the relation urine to plasma what matters. On the other hand, if the sum of your sodium and potassium in the urine is much higher than the serum sodium, for example, in this example, 180 divided by 120, meaning that you lose more electrolytes than electrolyte-free water, automatically your serum sodium should fall. On the other hand, if it is much lower, so you lose more water than electrolytes compared to the serum sodium, your sodium should go up. So it's a good parameter to measure, easy to measure. You take a sample of urine, you measure the sodium and the potassium, you relate it to the serum sodium, and you have an idea what you can expect from the serum sodium. Hyponatremia is the most common, the most frequent electrolyte disorder in any hospitalized patients. In outpatients, it's rare. It's most frequently in hospitalized patients, indicating that it is often physician's interference or nursing interference that induces the hyponatremia. And it can be, and it has been calculated or estimated that in a huge number of hospitalized patients, approximately 15% suffer from hyponatremia. It's a very important parameter. It is associated with increased morbidity. That doesn't mean, and that is also a concept you have to teach your young people, it doesn't mean if a patient dies and he has hyponatremia, that he dies from hyponatremia. No, it's an indicator that the patient was very ill, and that something in his tonicity in the blood has been affected by any other underlying disease. It's not a diagnosis, hyponatremia. It's a sign, it's an association It is associated with increased length of hospital stay, again reflecting that the patient is much more ill than the patient who has no hyponatremia. It certainly is associated with increased risk of death, even mild hyponatremia, meaning between 130 and 135 is a risk factor for being associated with mortality. So it's an important sign. It's not a diagnosis. I continuously will repeating that. Very confusing to the young physician confronted with hyponatremia is that all of the symptoms are playing in the head. What happens if you're hyponatremic? Most of the time you're hypotonic, meaning the tonicity in your extracellular fluid is lower than in the intracellular fluid. So water flows from extra to intracellular. So all your cells swell. They all take up water. In most of the organs, the other organs can swell. There is, however, one organ that cannot swell, and that's your brain. Some members of my faculty may have some swollen brains, but these are exceptions. But most of the people, when the cells swell, because they are limited by the skull, you cannot swell your cerebral cells. So there is cerebral edema, there is intracranial pressure elevation, so there's no surprise that all the symptoms are really presenting like a neurologic syndrome. And that is maybe sometimes surprising to a young physician. He may be confronted with, particularly an elderly, with memory disturbances. If it is mild hyponatremia, you immediately never think on hyponatremia in an elderly that has a little bit memory loss. I have it all the time, despite having a normal sodium. I hope, I never measured it. Or headache, or lycargia, or attention deficits, or confusion, or restlessness, or agitation, or vomiting, or muscle cramps, falls, I will come back to that, and an elderly falling, meaning fractures, which is a risk by itself. And then in serious cases of hyponatremia, you see this scale is going from mild to severe, and we speak here about 120 or lower, and the lowest plasma sodium that I have seen in a patient was 96 millimole per liter. But these patients may be in stupor or in coma, may present themselves as an epileptic one. So please, neurologists, pay attention to the electrolytes. If all of a sudden a patient is admitted in the emergency with epilepsy and never had epilepsy before, please check the electrolytes, because it may be the first manifestation of an acute hyponatremia, coma, and then, of course, also increased mortality. Now, the European Renal Best Practice Guidelines, under the superb guidance of Professor Van Biesen, has, since there were no guidelines on hyponatremia, or there are many world authorities on hyponatremia, mostly in the United States, just to name a few, Bob Schreier, Halperin, Verbalis, and others, Stearns, etc., who have written very nice chapters on hyponatremia. There were no specific guidelines. So the ERBP has come up with guidelines which are very good, which have been published in NDT, but also in endocrinology journals, and I recommend to read them. If you're interested in hyponatremia, this is really a very, very nice text. What they did, and I think this was important, when they made a hierarchy of the outcomes in plasma sodium disturbances, they categorized three categories. Critically important, you will agree that patient survival is a critical element, presence of coma, presence of brain damage and brain edema, epileptic seizures, osmotic demyelinating syndrome, I will come back to that, respiratory arrest, quality of life, cognitive function, meaning memory and reasoning, etc. And then highly important, they call bone fractures, falls, length of hospital stay. And surprising, it's not surprising because I agree with that. But maybe surprising, since we're talking about hyponatremia, they found only moderately important was the serum sodium concentration by itself. Because the serum sodium concentration by itself, as I said, is not a disease, it's a marker of comorbidity. But the results, all or not directly caused by hyponatremia, of the presentations are much more important. Meaning that the first reflex, you see a hyponatremia, and a young physician thinks, immediately he jumps on that and wants to treat it. No, in most of the cases, you have time. You have time to reflect, to see if there are one or more of these symptoms, and depending on the severity of the clinical presentation, and of course the serum sodium concentration, you have to act immediately, or you can wait and think about it. It is rarely, there are emergencies in acute hyponatremia, but it's rather rare. Most of the cases are chronic hyponatremia. Just to remind you, this is the serum osmolality. It should be actually more in this famous textbook, and I discussed that with Dr. Flüge. It should be saying here tonicity, actually better than osmolality. And you see when the osmolality goes up, the vasopressin, the antidiuretic hormone, is going up. And the concentration, the osmolality in the urine also goes up. We are not desert rats, because we can only concentrate maximally to 1200 milliosmoles. That's 4 times the concentration in the blood. A desert rat who has no water during months can concentrate up to 3000 milliosmoles just to conserve the water, because it has no water, or very little. So in relation to that, you see this blue line, and it gives you the level of the antidiuretic hormone in the blood. Because normally, when your tonicity falls, your vasopressin should fall and even become unmeasurable. When your tonicity goes up, your vasopressin immediately goes up. It's a very fine-tuned system. Very important, antidiuretic hormone regulates what you can excrete as water, but it doesn't regulate what you can drink as water, or as alcohol, or as whatever. So you see thirst, very strange enough, not strange at all if you come to think it, that is as soon as the tonicity goes up, immediately in most of the people, thirst sensation increases. So that if you become here dehydrated, meaning you have too much tonicity, so you lack water, immediately you have the urge to drink, and particularly cool water. If you have seen a diabetes insipidus patient, he will prefer, give him a tass of hot coffee compared to cool water, he will go for the cool water. That's the thirst feeling that these people have when they become dehydrated. A very important point, and I draw the attention of Professor van Biesen to this slide, and I will tell later why, is that in many cases of hypotonicity, where you would expect that there is no thirst, why should you drink if you're hypotonic? In many cases of so-called Schwarz-Bartter syndrome of the inappropriate secretion of ADH, very common, I'm sure you all know about this, that in many of these patients, they have also a shift in their thirst feeling. So they become thirsty despite being hypotonic. Now, one of the major approaches to a, let's say, chronic hyponatremic patient, where you think he has a SIAD, a syndrome of inappropriate secretion of ADH, meaning he has vasopressin while he should not have vasopressin, is saying you should drink less. That's the first thing. But the guy, poor guy, has thirst. How can you tell him to be a martyr of thirst if he has thirst? So one of the reasons why water intake restriction in a patient with hyponatremia often does not work, although it should work, but often does not work, because these people are thirsty. They want to drink. So that means that maybe that's one of the reasons why this is very often a failure of the therapy. Another important topic is you have the tonic regulation of water balance. And I told you, osmoregulation, when you become hypotonic, you inhibit your osmoreceptors in your hypothalamus, you suppress your antidiuretic hormone, you suppress your thirst, so you suppress your water intake. Because the antidiuretic hormone is suppressed, you can excrete water. Because that's what you want to do. You want to become isotonic again, because you have too much water. On the other hand, if you're hypertonic, you stimulate your osmoreceptors, you stimulate your thirst, you stimulate your antidiuretic hormone. So on one hand, you increase your water intake, due to the stimulation of antidiuretic hormone on the collecting duct in the kidney, you can retain water and you come back again to isotonicity. This is the classical, as I showed you in the previous slide, tonic regulation of thirst and antidiuretic. Most of the cases of hyponatremia forget about this system. Because despite being hypotonic, most of these cases still have vasopressin. How is that possible? Since if that system would work, if they are hypotonic, they should have no vasopressin. In most of the pathologies that we see with hyponatremia, there is a non-osmotic regulation of vasopressin, where vasopressin is stimulated by other things than the tonicity. And that is important. Look what these other things are. Nausea. Postoperative patient is nauseous. The anesthesiologist says, well, that's from the anesthesia. So the doctors give him some hypotonic fluids. He's nauseous. He has a high level of antidiuretic hormone. He may go into post-operative hyponatremia. The most common cause of post-operative hyponatremia is that particularly surgeons and anesthesiologists who do not know very well the physiology, they are afraid of salt. There's only one thing where a surgeon is afraid of, that's salt. So he wants to give a little bit salt and a little bit of fluid, so what he does, he gives glucose 5% or hypotonic solutions to a patient who has nausea, who has pain, who has received analgesics. So you give him water, and at the same moment you stimulate his vasopressin. So the water that you give is retained in the blood. So that patient becomes hyponatremic. If you are called as a consultant to a post-operative patient who is a little bit confused, who is not very well, doesn't speak coherently, and the surgeon and the anesthesiologist never have taken a blood electrolyte sample, checked for hyponatremia, and looked what kind of fluids that this patient is receiving, I bet you 95% of the cases he will have received hypotonic solutions. Don't forget that. There are many other non-osmotic or non-tonic stimulators of vasopressin. Hypotension, for example, by itself. Don't forget vasopressin. It's a vasopressor. So it helps to maintain blood pressure. When the effective circulating blood volume is low, by volume receptors, this one by baroreceptors. And do not forget, many drugs are stimulators of ADH. The most common one, at least in the States, but also in Western Europe, are the selective serotonin reuptake inhibitors, which are drugs very common